Let's begin. Dear friends and colleagues, welcome to this 25th Zoom meeting of the SOTCOT Mondays, realized this time in collaboration with the SIOT, the Italian Society of Orthopedics and Traumatology. And as you see, our scientific events is getting more and more international, and we are very happy about that. So the topic for this evening will be the management of diabetic foot. This topic is rarely discussed in orthopedic surgery, I must say, not only in Tunisia, but also in the rest of the world, despite the fact that it is a frequent and serious complication that can lead to major amputations, and these major amputations are correlated with a high mortality. So we'll try to have clear and simple messages at the end of this session. So I'm very pleased to coordinate this event in collaboration with our dear moderators, Dr. Ramzi Bouzidi. I hope he will make it to join us. He has some problem of connection. He's the current president of the SOTCOT. Dr. Karim Ben Aisha, he's the current president of the Tunisian Study Group for Foot and Ankle Surgery. Dr. John Abdenour, he's from Lebanon. He's representing the Arab Board, and he will be the voice of the Middle East of this in this event. And from Italy, we will have two top surgeons of foot and ankle surgery, especially in diabetic foot. I named Dr. Antonio Volpe and Dr. Marco Zamperetti, representing the SIOT. We're very happy to have all of you. So I would like just to remind all the participants that this is an interactive presentation based on cases. You will have some quiz to respond during the presentations, and also you can ask your questions on the Q&A box, the chat box in this session. So please turn off your mics and enjoy your webinar. And I invite the first speaker, Dr. Amin Salman, the assistant professor in the Ben Arous Trauma Center in Tunis, and ask him to share his screen. I will stop sharing the screen. Can you please share your screen, Amin?
Yes, thank you. Okay, so we're going to start with the first case. It's about a female. She has 52 years old. She has diabetes type 1, and she had a phlegmon in her right foot. And for that, she has undergone surgical excision 3 times. And in this image, you can see the final aspect of the scar. It was clean, with large loss of substance in the medial and the lateral aspect of the foot and the ankle. So we're going to begin with a question for the audience. What do you propose as a treatment for this patient? Hyperbaric oxygen therapy, moist wound therapy, negative pressure wound therapy, traditional wound care, or further surgical excision?
Can vote.
You have to respond to the question.
They're responding.
Okay, because I don't see the
few seconds, and we have the result of the poll.
Okay. Oh, great. So we have 80 to 80% for the negative pressure wound therapy. That's the subject of the presentation. So that's what we've done. We've made the vacuum assisted closure for this patient. It's the negative pressure wound therapy. And we're going to see the evolution at 15 days. As you can see in this image, there was clinical improvement, but we had a persistent coverage gap in the medial aspect, and good healing of the scar in the lateral aspect. At 3 weeks, things were improving. 50% vacuum coverage of the gap and 40% healing of the scar. At 1 month, we had 50% healing of the lesion in the medial and the lateral aspect of the foot. 1 month and a half, we were almost 65% healing and 95% in the lateral aspect. And here is the final aspect of this treatment at 70 days postoperative with 100% healing. So if we look in the literature with diabetic foot and negative pressure wound therapy, we're going to find it is a really hot topic with just 250 papers and just in the last 20 years. So this procedure, it has been reported that it is effective in diabetic foot ulcers with benefit in healing, wound care reduction, and mainly in the prevention of amputation, which is a real problem in orthopedic surgery. And this is true for low-cost and conventional procedures. And if we compare this procedure with advanced moist therapy, such like hydrogels, hydrocolloids, alginates, etc., we can see, as we can see in these two papers, the conclusion was that the negative pressure wound therapy has better healing outcome, faster wound size reduction, fewer infection and recurrence rate, and can lower the amputation rates. But all of that with a slightly longer time to closure, which is not, I think, a big problem. But what are the long-term benefits and cost effectiveness? These papers respond to these questions. So this procedure can reduce the number of amputation and can increase the healed wounds with a greater cost effectiveness compared to traditional wound care and to the moist wound therapy. And this is especially for the outpatients. So you have to know that this procedure can be made at home with patients at home, not at home. So for conclusion, we can say that the negative pressure wound therapy is a real gate of hope for patients with diabetic foot ulcers. Thank you.
Thank you, Amin. Thank you. Very good presentation. So this is to emphasize that diabetic foot is not only about surgery. We can have non-surgical techniques, that non-surgical debridement that can be very efficient. So you said that using the negative pressure wound therapy is cheaper than classic methods?
Yes, yes, less costly than traditional wound care and the moist wound therapy like hydrogels, alginates, etc. Especially for outpatients, because it's a procedure that you can make at home. The patient can put this wound therapy in the hospital and come back with it at home.
Okay. And the duration for usually the duration for the device, the use of this negative pressure device, you put it for how much time usually?
It's for yes, several days. It can be put for 5 days to I think 7-8 days.
Now then you have to change it.
Yes.
Okay. Okay. There any question in the?
Yes,
among the
I have
5 questions.
Yeah. I would like to congratulate Dr. Amin for this nice case. But as a whole, I would have liked to know, is this patient well controlled? I want to ask from Dr. Amin, what is the chance for this patient to have a recurrence of the lesion? this is something. Now, I agree with him that the patient was treated at home. Why? Because whenever there is evidence that there is no infection, we can allow the patient to be treated at home. But they need constant changes of dressing. And the vac is really hectic. You have to really continuously change it, and it needs special care. So I'm kind of wondering about this. What do you think, Amin?
For the recurrence rate, I think this is the diabetic food is a real. It needs multidisciplinary management.
Exactly.
Because it depends on the
balance of the diabetes.
Yes, balancing her diabetes, etc. So the recurrence is very changeable.
Okay, thank you.
All of these.
That's just so the audience would know this only.
Not
they
only
need
this, yes,
constant
not only this.
care.
The recurrence, yes, not only this, but also we have to be vigilant with the change of the with the wound care at every time, and with infection in this lesion, because if we have infection, this will it will be very long to treat this patient. Yes.
Yeah.
Yes.
It will take a long time.
For diabetic foot, I think multidisciplinary management is the key point, because we have to manage the infection, we have to manage the diabetics, we have to manage the wound, and clearly we have to use multidisciplinary management into committees or even in some departments that specialize in this complication. Okay, if there are no other
in the chat, yeah, Mohammed.
Yes, a question in the chat. Yes, sorry. To record that
I think it's important to look at.
Yes, we need a good debridement before applying the pressure, negative pressure. Moaz, tu peux fermer ton micro. A gentle reminder for everyone, please turn off mute your mics, please. Thank you. So the question from the audience was that we need a good debridement before applying the negative pressure. Of course, we need the debridement, surgical debridement, but this can be also non-surgical debridement. We can use it as a non-surgical debridement.
Actually, the patient needs a full workup before deciding on any form of treatment. You need x-rays, you need radio imaging, all the types, you need a CRP, you need a sedimentation rate to rule out an infection, etc. And then you can do whatever you want.
Dr. Abdul, I think it's important to make vascular exploration in that kind
Exactly.
The rate of healing is much better if we have a good condition in the vessel.
There are so many studies you can do that will help you in deciding the prognosis of the patient.
Mm-hmm.
Another point I want to ask Dr. Amin, when would you allow your patient to walk or bear weight? That's another question that bothers us, surgeons.
Yes,
when to allow them to bear weight?
Yes, because with the vac therapy, in general we offload the patient. We don't weight bearing. We don't allow weight bearing for the patient, and it's in general we have to we can permit the patient to weight bearing with when we have a good healing. Just I think 100% healing of the scar.
Mm-hmm. Thank you.
Okay, I think we can move to the second case. So our second speaker will be Dr. Qais Nigru. Can you share your screen, Qais? So Dr. Qais Negro is a private practitioner here in Tunis, and he's no.
محمد راشد اللي فوق محمد كيفي
أهلا وسهلا.
مرحبا مرحبا
مرحبا سي محمد.
أهلا وسهلا. So, Qais, can you please share your screen?
Yes, I will share my screen.
الله يسلمكم وكل سنة وانتم طيبين على التعليم اللي يديروا فيه دائما. مشكورين.
Thank you.
شكرا دكتور راشد. شكرا. So Qais was the former president of the Tunisian study group for foot and ankle surgery. Now he's a private practitioner here in Tunis. And Qais, can you? Yes.
You see the screen? It's okay?
Okay.
Can you? Yes. Okay.
It's okay?
Yes.
Yes, go ahead.
So, dear colleagues and friends, hello everyone. I would first like to thank the organizers of this Orthopedic Monday for inviting me to participate, and I would also thank Dr. Karim Ben Aisha, who kindly agreed to share this observation. So it's a history of 38-year-old woman, type 1 diabetes from 15 years, and he had a minor right ankle trauma at October 2023. And these are the radiographies, the anterior, posterior, and the lateral view. So this patient had a functional treatment with an orthotic device, and then she was lost follow-up. And 4 months later, she complained of warmful, painful, and edematous ankle. And here is the radiographic appearance of his ankle with these lytic lesions of the inferior part of tibia and the anterior inferior osseous fragment without any dislocation or deformation of the ankle. So the patient was treated with a removable walk boot device, and 3 months later, these are the radiography with the increase in the size of lytic lesions. And the same thing 2 months later. So the total duration of immobilization with a removable boot walk was about 5 months. And given the lack of improvement on clinical and radiological level, a CT scan was requested, and here is the appearance with the imported lytic lesion of the inferior part of the tibia and destruction of the talon joint. So the patient had tibial arthrodesis with an autograft from the iliac rest fixed by 2 screws as shared here in the radiographies. And this is the last radiography 8 weeks after surgery. So the question here I want to ask you, did the therapeutic approach at the beginning, and I will return to the beginning. Sorry. So what do you think about this initial radiography, and did you think that the therapeutic approach was good or not? First question.
Yes, it was a simple ankle sprain. I think it was a logical treatment.
I have a comment, if you would accept.
Yes.
My comment is, I want to know more about the patient before you did this procedure. Now, we presume this patient has a Charcot joint, but does he have an associated infection? That's another point we would like to know. Now, about the treatment that was given, we agree with you. We agree with the arthrodesis, and that's it. But we should investigate our patient more before any form of treatment. That's the whole purpose I'd like to mention.
هذا أخ مسعود، هذا أخ مسعود، هذا استلت ليه هو.
Yes,
أخ مسعود
sorry,
هذا.
but
هذا نزل
sorry,
لكل المواضيع مش الهب بس.
Please, everyone have to shut up.
حمله زي
Please,
التطبيق عندك في التليفون.
please,
أنا حملته.
please, here.
كويس كويس. أنا
Can you turn off your mics, please? We are hearing you. Please, everyone, turn
Yes.
off his mic.
I do this.
And let the speakers and the moderators, please. Thank you. Yes.
Sorry,
Yes,
but yeah, the first question is about the initial treatment, not after
Exactly.
complication. After this initial radiography, do you think that it's a radiography of a simple ankle sprain, or there is other
Let
thing?
me tell you about the radiography. When I first saw the radiograph, I saw cystic changes at the distal end of the tibia. Whenever we see cysts, we worry a lot about infection. You got the point? This is something which is very important. Now, this patient had two things that occurred with him. He had an inflammatory process, which is stimulated by the interleukins and the tumor necrosis factor, and as a result, developed severe osteoporosis, ending up with multiple fractures, which occurs with Charcot joints. Now, your fusion will do good, even for infection. I congratulate you on doing it, but I care a lot about residence investigation prior to any form of surgery. Thank you.
Okay, thank you. So in my opinion, in this initial radiography, I have a problem with this syndesmotic
joint.
I think that yes, the syndesmotic joint, probably we had to do a CT scan here to
maybe yes, it would have helped you, or an
yeah.
MRI.
Yeah, an MRI or a CT scan to see more this the function or the situation of this syndesmotic joint, and after that the second question is about the therapeutic approach after these images. You ask me about the infection. There is no infection in biology, or we have just a painful, woeful ankle with these lesions, but in the biology there is no signs of infection, and no vascular problem in the exploration. So that we decide at the beginning to immobilize the patient with a boot walk device, and after that there is improvement. For that, we had decided to make the arthrodesis after lack of improvement after 5 months of observation.
Mm-hmm.
So did you think that this arthrodesis is the good therapeutic approach or not?
Definitely. I don't know what the group thinks. It's my personal opinion. It definitely has a place in the Charcot joint and in an infected ankle. And if you look around, look at the calcaneus. The calcaneus is very osteoporotic. This patient has a severe form of the Charcot joint. I think for 15 years, this patient had a peripheral neuropathy that led him to this. And poor treatment, poor management. Thank you.
Dr. Volte, your opinion about this case?
From a clinical point of view, in the early charcot, one clinical point is the increase of the skin temperature between the two legs. This is, in my opinion, all traumatic lesion of ankle or foot in potential neuropathic patients. We have to check very well the increase of the skin temperature. And other question, MRI for me is very important, because when we see a bone edema, especially in T2 section, this means there is similar to the algodystrophy, there is a high risk to develop a Charcot the progressive deformity. Other observation is you have to protect for very long time this ankle, very well operated, but the risk of recurrency or instability is high. So it's very important our patient to apply a very close medical control every month, and also to control the position of the foot, because this is a very good arthrodesis for standard patients, but not so stable in the charcotic bone.
Do you think that the fixation device is good here?
Yeah, it's very good for me. Okay. But the problem is in Charcot you can have a subtalar instability and a mid-tarsal instability that can be progressively go to the deformity of the midfoot or to the rear foot. So it's very good fixation for a standard ankle, not so safe for a charcotic bone.
Okay. So after that, I want to share you in the literature this is a reference paper published in 2015 in the diabetic foot and ankle, and according to this publication, about 17% to 55% of patients who had Charcot foot had a minor injury, such as sprain or twisting injuries. So first lesson here is that when there is a history of minor trauma in diabetic that does not improve within usual time frame, with ankle remains swollen, red, and painful, it must be considered as a Charcot foot until proven otherwise, and treating accordingly. So this is the first lesson. After that, in the acute phase, conservative or surgical treatment. So the mainstay of treatment of acute Charcot has been the conservative treatment, and there is no consensus about how to allow or to not allow white bearing. And after that, surgical treatment is generally reserved for stage 1 of Charcot foot, but some authors described this treatment, the surgical treatment, even in stage 0. So I want to ask you about your attitude here. Did you treat Charcot at stage 0 or not? For surgical treatment.
Dr. Volpe, do you treat surgically Charcot foots
in our
at
opinion,
a very early stage?
The stage 0 is the Shibata stage. We have only clinical suspect of Charcot, no deformity, and in our experience, the treatment is no weight bearing time with contact cast for the time necessary to reduce the inflammatory sign. And in our experience, usually we treat surgically the Charcot in the stage 3 of the Eichenholz classification. So the quiet stage of Charcot, not the acute phase. In Italy, some people use diphosphonate therapy.
Yes.
Treatment in the literature is to treat with this medical approach or not.
Sorry, but in this based guide to treatment, biphosphonate are not very effective in the treatment of Charcot.
I don't have
this is the conclusion of this
to go and answer about this theme. Okay, yes. But in Italy, a group of Professor Pitocco from University of Rome shows some advantage with the use of biphosphonate, but I don't know if this treatment is effective or not.
And I would like to interfere about biphosphonates. Biphosphonates, we all know about the function that it acts against the rankle, which is produced by the osteocyte to the osteoclast through the osteoblast. Now, biphosphonates is preventive, not used in the treatment. I think we don't use it that often. We've used calcitonin, for instance, yes, but I'll tell you, to be honest, it's only preventive. And I would like to comment, as I recently heard from this nice speaker, that we operate only in stage 3, not stage 1. Stage 1, we should try and prevent it medically. I'll tell you one thing. The problem with Charcot joint, it occurs during the period of maltreatment, where you don't have a good control of the FPS, where the HbA1c or 1c is not controlled. We try and treat these patients, and by delaying weight bearing, etc. So this is a point I would like to stress on. I've rarely operated on a patient with Charcot's joint throughout my 55 years of practice that was in stage 1. I only operated on them in the late stages, where I did an arthrodesis, or as you have done, to prevent. Now, I agree with you that what you've done is correct. It's not wrong. You've done a good procedure. It's holding well. But the problem is, will it unite or not? That's the question. Thank you.
Thank you, Dr. Johnny. We have to stick to the time.
Okay,
and,
thank you.
We are moving to the next speaker, Dr. Karim Ben Aisha. Can you please share your screen? So Dr. Karim is a private practitioner in Sous, Tunisia, and he's the current president of the Tunisian Study Group for Foot and Ankle Surgery. Yes, Karim. Full screen, please. Yes. Karim, you are muted. Don't hear you.
Thank you.
Okay.
So I'm delighted to welcome you all to this session on diabetic foot management, its complications, and surgical treatment. I have the honor to co-moderating today's discussion, and I will present 2 cases of diabetic foot ulcers. As we know, diabetic foot complications remain a significant challenge in healthcare, leading to severe morbidity and in some cases, even limb loss. Through these cases,
Dr. Nidal, can you turn off the mic?
Please turn off your mics, please. Everybody turn off his mics, please. Thank you. Dr. Karim. Yes.
Through these cases, we aim to explore the latest advancements that can improve patients' outcome. The first case is a 67-year-old patient with plantar diabetic right foot ulcer that has been evolving for 3 years. Despite local care, the condition has not improved, especially with large maceration. This has significantly impacted the patient's daily hygiene. The X-ray shows a verticalization of the metatarsal bone. What would you do for this case? Debridement and confection of insoles, debridement and offload for 1 or 2 months, debridement and vac therapy, resection of the head of the second and or third metatarsal head, or a distal metatarsal osteotomy. Yeah, the results. So 30% for distal metatarsal osteotomy, 30% for debridement. Yes, good debridement and vac therapy. So for this case, I decided to perform. I decided to perform a minimally invasive percutaneous distal metatarsal diaphyseal osteotomy called DMDO to decrease the hyperpression of the metatarsal head of the second, third, and fourth metatarsal bones. The operation was made under fluoroscopy with minimally invasive approach for 3 millimeters for each metatarsal osteotomy. On this video, you will see the real duration of the distal metatarsal osteotomy. Here you see the final look with only 3 stitches, 1 for each metatarsal osteotomy. The postoperative dressing is dry, without additive topic, and weight bearing was allowed from the first day. Here you see the aspect at 10 days without any wound care. And the patient can work immediately after the operation. This is the appearance at 3 weeks, and the X-ray shows the presence of bone callus. At 6 weeks, at 3 months, 6 months, and 6 months with a very good consolidation of the osteotomies, and then at 1 year. The second case is a 65-year-old male patient with plantar diabetic right foot ulcer at the level of the head of the first metatarsal bone that has been evolving for 6 years. This type of diabetic foot ulcer is difficult to treat because it was a support zone on working. I decided to perform a minimally invasive percutaneous DMDO at the first, second, third, and fourth metatarsal bone to respect the maestro parable and the harmony of the forefoot. The postoperative dressing is dry, and the patient was authorized to imitate weight bearing. And you see here the appearance at 1 week, at 2 weeks and a half, at 5 weeks with bone callus on the X-ray, 7 weeks, 12 weeks with good consolidation of the osteotomies, and finally at 1 year. So the chronic plantar diabetic foot ulcer, the annual incidence of the chronic plantar diabetic foot ulcer is 2 to 6%. More than 50% of these became infected, and more than 15% of the infected diabetic foot ulcer lead to some level of amputation. In absence of ischemia, chronic foot ulcer heals when offloaded, but it does not change the underlying mechanism causing the pathology, especially here, the hyperpression, the plantar hyperpression of the forefoot. So we have recurrence in 40% at 1 year and 60% at 3 years. The DMDO, distal metatarsal diaphyseal osteotomy, is a smart technique without fixation, without immobilization, allows immediate weight bearing for the patient. It decreases local complications, especially skin complication, accelerates healing between 6 and 8 weeks. And the most important point, it prevents recurrences. Thank you for your attention.
Thank you, Dr. Karim. I will ask another time, please turn off your mics. Dr. Abid Fawzi, please, can you turn off your mics? Thank you. So thank you, Dr. Karim, for for these two interesting cases, very spectacular healing obtained at the end of your procedure. Do you experience recurrences? You spoke about that it prevents recurrences, but do you experience recurrences, the récidive, for this technique?
Yeah. I see recurrences when the foot is multi-operated, okay, for phlegma, for the diabetic foot ulcer. So the fibrosis, elle empêche. Comment dire, elle empêche? C'est the fibrosis. When we make the osteotomy with the fibrosis, the head of the metatarsal cannot move, cannot change of placement. So the ulcer cannot heal, or it heals partially, and then totally when offloaded, and then we have recurrence. So it's good to operate them first time, yeah. It's better.
First hand surgery.
Yeah. In one case, I saw a Charcot foot, but with good follow-up after immobilization.
Okay. May I ask a question? When you do this operation and you allow them to bear weight early, do you put any padding underneath the heads so as to push them up, or what?
No, I make the operation the first time when I see the patient. They come after 1, 2, 3, or 3 years with this diabetic foot ulcer, and I make the osteotomy, and the full white bearing is the first day with normal with medical shoes, but without offload.
You don't put the cast on.
The full white bearing, with full white bearing, the head of metatarsal will be replaced in the good position, accelerate healing. Because the problem is the hyperpression. When we make the floating osteotomy and we authorize weight bearing, the head of the metatarsal will change the place, and that's what we search for this operation, to change the head metatarsal position to decrease the hyperpression in the forefoot, in the plantar forefoot.
Dr. Abdunnoor said that if you put a pad under the heads to improve the movement to the dorsal side of
the pressure within a cast.
No, when the patient working, he makes the pressure in the metatarsal head, and it will change automatically the position and it will be the good position because of the biomechanic of the food, of the wall.
Very interesting. Thank you.
Sorry, may we ask a question?
I have a question for Dr. Karim.
Yeah.
Hello.
And
Dr. Volpe, please, yes.
Yes. In Italy, we know very well that in the mini-invasive surgery with DMNO, it's very important to allow the immediate weight bearing because the position of the metatarsal head was accommodated by the full weight bearing. And this is a philosophy introduced by my friend Prado, also in the standard patients. But in this kind of patients, my question is, what do you think about Achilles tendon lengthening in contemporary surgery in this kind of patients? Because we know in these patients, the Achilles tendon is quite retracted due to the diabetes situation, and some authors said that Achilles tendon lengthening can treat and prevent forefoot hypertension.
Yeah, we can do it, but the clinical examination, when we don't have the retraction of the gastrocnemius or the Achilles tendon, we don't make any operation for the Achilles tendon. If there's a retraction of the gastrocnemius, we have to do a tenotomy of the gastrocnemius, medial gastrocnemius, to improve the biomechanic of the walking and prevent the hyperpressure.
Okay, so the silver curve test is very important to assess this kind of patients. Very important.
That's what I said. The clinical examination silver skull test, and we will choose if we make the lengthening of the medial gastrocnemius or not.
Okay, thank you.
I may ask
you.
Sorry.
Yes, Dr. Marco, sì.
For the second case where there was the ulceration under the first ray, why not to do osteotomy only in the first ray? In the first
yeah, because the second metatarsal bone was too long.
Okay.
You see, when I will make the osteotomy only for the first, it will you will have the hyperpression in the second and third, and we will have a diabetic ulcer in the middle of the forefoot. So when I make the first, second, third, and fourth, I preserve the harmony of the maestro parable, and we don't have a transfer of hyperpression in the other rays. Probably, if the patient second metatarsal normal, not length, we can make only the first. But for this case, the second is too long, too long.
I agree.
Yeah.
Okay, we have maybe a question from the audience.
Yes, hello.
Hello.
Yes, Yamin is speaking from Lebanon, from the Lebanese American University. I'm head of the diabetic foot clinic and orthopedic surgeon.
Awesome.
So we have a lot of experience in the distal metatarsal osteotomies. We did recently, a few years back, a systematic review and meta-analysis about this technique. I would like to put my contributions here. First, the question asked by, I think, Dr. Marcos about the first ray. Why should we do the other rays? The thing is, maestro line is about the length of the metatarsals and not the dorsoplantar displacement. So yes, when we have a too long second metatarsal, it's obvious we need to do the osteotomy. However, when we don't have it, it's better not to do it, because we are not interfering with the length. Here we are interfering only with the dorsoplantar displacement or transfer that we are doing. This is one. Second, Now it's a trend for many invasive surgery. I agree, but still, the few times that I did it, I always see a gap, and a huge gap in the site of osteotomy. Reason why I switch back to the open osteotomy is like 0.5 centimeter, 1 centimeter, and I do my osteotomy without, when we are using the burr, we are removing like 4 to 5 millimeters of bone. So I don't like to see a gap in the osteotomy when I do it, and it's more complication like such non-union. So really, it's a great technique. I think it's a technique not pretty much underused, and it gained time for the patient. And I congratulate Dr. Karim on these two cases. It's excellent result, as you can see. Thank you.
Thank you, Dr. Qaisi.
So just to respond briefly, Dr. Abdelkafi, when we have a gap in the minimally invasive osteotomy, we will have all the time, at 95%, we will have a consolidation. So I operated all my patients for the diabetic foot ulcer with metatarsal osteotomy, minimally invasive, and I don't have a problem for consolidation. Always a gap immediately after the operation, but the bone callus, it will be formed at the 4th or the 8th week after the surgery, and probably at 3 months after surgery. We have to be patient with the patient.
Yes, this is the proper of the percutaneous surgery. It's always consolidate usually. So we are running out of time, and we move to the next speaker, Dr. Ahmed Ben Abid. Can you please share your screen? Dr. Ahmed Ben Abid, an assistant professor at the Charles Nicolle Hospital of Tunis, and he will speak.
Thank you, Dr. Abdelkafi. I want to thank the organizers for the choice of the topic, which is often misliked the topic in orthopedic surgery. Do you see my screen?
Yes, diaporama, please.
Okay. So the first case is a 67-year-old man with type 2 diabetes polybalanced for 18 years, with a various ankle deformity for 1 year, who is unable to walk, as you can see on the video. The clinical examination, he has severe various ankle deformity, hyperkeratosis on lateral malleola, is unable to walk, he has irreducible deformity, a weak distal blood pulse, and no warmness of the skin. On his X-rays and CT scan, we can easily see that it is a Sanders type 4 Charcot foot, which involves the ankle, with almost total collapse of the talus. And the distance between tibia and talus indicates the presence of a big amount of fibrosis. We can see on the AP the shape of the two fibular tendons here incarcerated. And the last thing, we can see bone reconstruction here on the lateral X-ray, which indicates a reconstruction stage, which is Heichenholz stage 3 of Charcot foot. So, what would you suggest for this patient? Conservative treatment, bracing or casting, or offloading, TTC open fusion, arthroscopically assisted TTC fusion, or amputation.
Wait for the results.
Waiting for the results. Okay. And we see that more than 50%, almost 80% or 70% of the surgeons opted for a TTC fusion, and half of them open, half of them arthroscopically assisted, which is avant-garde because it's new, it's better for the healing. So we can go. So we decided to make arthroscopically assisted TTC fusion with the first step of arthroscopy. We can see the clinical aspect of the foot in the operation room. We started with posterior ankle arthroscopy in prone position. We start removing the fibrosis at the entrance of the joint. And we're gonna start removing that big amount of incarcerated fibrosis. You can see the remaining talar dome, which is moving here. And we keep removing the fibrosis to expose the bony surfaces with a shaver and curette. And we make asymmetric bone bearing to restore the coronal imbalance because of bone erosion on the medial side. And then finally, we're gonna see on the left side the incarcerated fibular tendons that we have to resect to be able to reduce our joint. So then we can use a transversal wire to reduce it, and then you can see that we start having an acceptable bone-to-bone contact. Then we go to TTC fusion. We use the nail. Unfortunately, in Tunisia, we don't have a dedicated nail, but we usually use a retrograde femoral nail. The only problem is that it cannot give you a compression, but we have some soft skills, not soft skills, but tips and tricks. We start by putting the distal locking screws, make a gentle hammering, and then fix the proximal locking screw. So this is the clinical aspect in the X-ray at the end of the surgery. We corrected the various deformity. And post-operative, we balanced the diabetes. We put walking boot for 3 months, no weight bearing for 3 weeks, partial weight bearing from weeks 3 to 6, and full weight bearing to the 6th week. So after 3 months, we are not sure that it's fused, but the patient walks, he's pain-free and with almost a good reduction of the deformity. But we missed one of the locking screws. It happens. Okay, the second case is a 72-year-old man with imbalanced type 2 diabetes for 24 years. He has evolutive right ankle deformity for 2 years. He had heel pressure sore 13 months ago after hospital stay for abdominal surgery, and now he has a productive fistula for 9 months. He's unable to walk. His CRP is 14 milligrams per liter, and an amputation was proposed by many surgeons, but it has been refused by the patient. So you can see the clinical examination that he has a very bad skin condition with some necrosis on the toes. He has a heel fistula here, and he's unable to walk with irreducible valgus deformity and weak distal blood pulse. On his X-ray, we can see he has also a Sanders type 4 Charcot foot with the erosion collapse of the distal tibia and valgus deformity, and the contrast product was going from the fistula to the ankle joint. What would you suggest for this patient too? So conservative treatment, TTC open fusion, TTC fusion with Elizarov external fixator, arthroscopically assisted TTC fusion with a nail, or amputation. So you can answer. So in a few seconds we will have the results.
It's coming, yes.
So most of the people decide to make a TTC fusion with Elizarov external fixator, which is logical with the presence of infection. And almost 30% decided to make arthroscopy assisted TTC fusion with a nail. Okay, so we were going to do an eraser of external fixator, and finally we decided to make a large debridement and arthroscopically and TTC fusion with the nail. So as we saw it in the first case, posterior arthroscopic approach for both joints. It didn't start. Okay. So in the same shape, we started removing the fibrosis at the entrance of the joint. We started with the subtalar joint, so that we identified and opened by using a burr, and then we removed the remaining cartilage by using 2 or 3 millimeters osteotome, and then with the curette we remove all the fragments for a better rate of fusion. Then we go upstairs to the tibiotalar joint to remove the cartilage, which is not too important, but it has a big erosion of the bone. And we start removing fibrosis and then burring to give to the bony surfaces a parallel shape or to have a good fusion. And this is the final aspect of the joint. And then we go for TTC nailing with a retrograde femoral nail. And this is a patient 3 weeks post-op. So we can see that the skin is in a much better condition. He started healing his fistula, which is not totally healed. And 5 months post-op, it is totally healed. And the patient is totally pain-free. He walks without cane. Well, he has a 2 centimeters leg-length discrepancy because of the bone erosion, but I think it's better than amputation. So in the literature, we were asking ourselves if we should consider primary primary surgical reconstruction of the Charcot foot of the ankle. So we can see that Charcot foot sandals 4 of the ankle. We have more than 60% of failure with the conservative treatment, and the failure of non-surgical treatment prolongs the treatment period. And the early surgical reconstruction at the Eichenholz stage 3 gives rapid restoration of a stable plantigrade foot and improves the quality of life of the patient. About the advantage of arthroscopy, we can see that in the literature it gives almost 75% of reduction in wound healing problems compared with open surgery. It gives a better vision, allowing resection of fibrosis and tendon incarceration, and it allows a better preparation of the joint surface to be fused and better fusion rate. But we are not able to do a good bone grafting and a correction of the leg length discrepancy. Thank you.
May I ask a question? My question is, your first case, I agree fully with what you've done. The second case, if this patient was a laborer, what can you expect from what you have done?
If he was what?
A laborer. Meaning he has to make use. What did you think he would be better off with his thighs amputation? I'm asking this question to you and to the group.
It depends also on his age. That guy is 70 years old. I think he's.
I know. I said if he's a laborer.
Maybe an amputation would have given him an early back to
and better function. I don't know.
Yeah. I'm not sure, but usually when we make a TTC fusion for arthritis, they can go back to work. So if it finally well fuses, why not?
Amputation was indicated for this case, and the patient refused it.
So the patient refused it.
Oh. Yes, it was a limb salvage technique. So we have a question in the audience. What is the mechanism of wound healing with fusion? Why the heals when you fuse the bone?
Because there is no more pressure when you have a valgus or varus deformity. For example, for a varus deformity, you have a big pressure from the lateral malleola on the skin, and the patient starts walking on the lateral malleola. So he starts having wound ulcer or skin ulcer. For the case of the fistula, the fact that we did an extensive debridement and removal of the infected and necrotic bone may have contributed to have skin healing or wound healing.
And Ahmed, do you use X-Fix with intramedullary nail at the same time or not?
No, I didn't do it, but we used external fixator in some cases when it was really impossible to reduce it or with a very infected foot. And even for the second case, we were thinking about doing it because of the fistula, but we didn't do it in that case. But not both at the same time.
Is any question in the audience?
Yes, I have a question, Kaysar,
yes,
again.
Kaysar, yes.
Thank you, Dr. Ahmad. I have two questions. First, you did the arthroscopy just from the posterior aspect, no?
Yes.
So
yes,
the anterior subtalar joint and the anterior aspect of the ankle joint were not worked out.
The subtalar joint, we fused only the posterior subtalar joint, yes.
Only the posterior.
Yes.
So I think in these cases where we have a pretty much fibrosis, maybe it's open technique could be a better option. I'm saying maybe, it's my opinion only. The technique that you use is excellent, but in these cases, very big deformity, and we have fibrosis still in the subtalar joint, anterior subtalar joint, and even the anterior talotibial joint, tibiotalar joint. I think perhaps the chances of union would be a bit less. Second, for the nail, for the second case that you present, I don't know if the nail is really the indication here. If you have a fistula, you have infection, so putting a nail inside the joint, why not opting for the external fixator as a rationale from your side?
Well, we were thinking about it, but as I had microbiologic proofs of which germ it was, we started the antibiotics 3 weeks before the surgery, and we did an extensive debridement. So I don't have a very strong scientific answer to your question, but we did.
Okay. Hopefully.
Just Dr. Abdelkif.
Yes.
For these cases, when we want to make an open procedure, we will have automatically necrosis of the skin, because the vascularization was poor in the skin for these patients. And for the arthrodesis, the arthrodesis of the posterior subtalar joint is sufficient to have ankylosis and arthrodesis of all the subtalar joint. We don't need to move the cartilage of the anterior subtalar joint. So we can work only on the posterior subtalar joint.
Dr. Karim,
it's sufficient to have the arthrodesis.
The rate of non-union following TTC in diabetic Charcot is like just 70%. So I think it might play to work on the anterior subtalar joint. I think second, and when we do it arthroscopically, we cannot put a graft. And I think grafting here, it would add to the stability and it would add to the chances of union. because we need, I think in my opinion, we need to do really everything we can for these patients the first time to give them a chance for union. Even in the best hands, it seems the papers are here like not more than 70% of union. So I believe, it's not maybe scientific, but I believe we need to go as much as we can, and we need to debride as much as we can in these joints, and before putting the arthrodesis on active.
Yeah, but open surgery in these cases, we can have
I never had skin necrosis.
Yeah,
I never had
of the skin.
I never had it. If you go laterally, mainly laterally, anteriorly, you might have skin suffering issues. Yeah, I agree totally. But when we go laterally, we remove the distal part of the fibula, and we have a total, you know, like autoroute, like the highway before in front of you about the tibiotalar and the subtalar. We can remove everything, and we can use the distal fibula as a graft. We can put also an allograft maybe. But when we go laterally, we don't have skin issues. Anteriorly, yes. Anteromedially, it might happen. Yeah, I agree.
Dr. Yamin, in recent papers, I'm seeing many studies about anterior approach for this Charcot foot of the ankle, and many of them are using anterior plates to fuse it, and they are removing only the cartilage of the tibiotalar. I don't know if you have seen some of these studies, and they have more than 90% of fusion for the tibiotalar joint, and they have more than 60% of fusion of the subtalar one, and they are saying that Charcot foot heals well.
I don't know. I'm not aware of these specific studies, but I'm aware of using plates, especially Japanese teams started with them.
And Koreans. And I've seen a Korean study where they do that same technique, but they use a tool that is used for endoscopic spine fusion to put small grafts. C'est comme un entonnoir, je sais pas.
Oui,
c'est comme un entonnoir. And they put it from the arthroscopic approach, and they put many small parts of grafts inside the...
Yeah, this is a nice technique, but you said about the anterior approach using a plate.
This is two different things. Yes.
Okay.
Thank you, everyone, for your intervention. And now we are yielding the floor for Dr. Antonio Volpe and Marco Zamperetti for their presentation. Can you please share your screen? And we will speak about Charcot foot reconstruction, beaming, X-fix, or both. Dr. Volpe.
Okay, and
share screen.
Okay, you see?
Not yet. But,
just a moment. Now?
Yes, it's okay.
Yes.
Coming.
Perfect.
Okay, and you put it in full screen, please.
Okay, thank you for the kind invitation. And let's start with some cases of reconstructive treatment of Charcot foot, of the midfoot and the hindfoot. Let's start with 3 cases of reconstructive treatment of the midfoot Charcot, and so the classic rocker foot deformity. Let's start with the first case, a female, 58 years old, diabetes mellitus from 26 years old, with a bilateral Charcot known since 2021 and a BMI of 26.8, and with a good blood supply of the foot. Okay, let's see. You can see the X-ray imaging. We have a midfoot Charcot stage 3. We have a inactive Charcot and isolated midfoot Charcot with a superficial ulcer, sometimes deep ulcer, but with not sign of osteomyelitis. What do you do in this case? what do you think to do in this case in a patient that don't want to have this ulcer, have a problem every month to the medication for the ulcer? We can think about we can think about to do the arthrodesis of the midfoot with diabetic fixation, or arthrodesis of the midfoot with beam, or nothing and continue with a cast and the insole and the personalized insole. Okay. I think that we'll think to do a realignment and stabilization with every external frame, and we choose to do. Sorry, we have a problem. We choose to do arthrodesis with beaming. In this case, we usually do we usually use the G beaming that are a very big beaming. The main beaming in the first ray is 7.4 millimeter diameter, and the beam in the lateral side of the foot is 5.4 millimeters diameter. We like this kind of reconstruction because we have other arthrodesis beyond the lesion area to include the normal joint. In this way, we have an increased stability. Here, the technique, we have two stages. The first stage, we have a continuous part where we do a lengthening of the Achilles tendon. We can do this lengthening with a gastrocnemial resection or with a percutaneous Achilles tendon lengthening. We prefer the first technique because it is more reproducible in our hand. After that, we fix a 90-degree the ankle with a K-wire for the stabilization and to have more see here to have the foot in the right position for the osteotomy. After we did the medial approach, we remove the fibrotic tissue and we do a full thickness bone resection with a plantar wedge bone osteotomy to increase the medial arch. After that, we implant the beaming. I like this procedure because in this way the hardware is inside the bone, and I have a lower risk to expose the hardware in event of a wound complication. Here the result, you can see the two beaming. The main beaming is the 7.4 millimeter beam, and in the lateral part we have the 5.3 millimeters. Here you can see the lateral X-ray with a nice reconstruction of the arch. And after that, the patient have a no weight bearing for at least 3 or 4 weeks, no, 3 or 4 months until we see sign of consolidation in the X-ray. Let's go with the second case in the male with 74, with 63 years old, with diabetes mellitus from 20 years. He has a Charcot since 2019 with a good blood supply. He have a problem with chronic superficial ulcer, and we have in this case the inactive Charcot with a desolated midfoot Charcot with no sign of osteomyelitis in the MRI. And so what to do in this case? we can repeat the beaming, or we can do the basis with external hybrid fixation, do nothing and continue with the orthopedics boot, or put a not weight bearing cast.
Just a few seconds for the result.
And win the hybrid external fixation. Okay, in this case, I repeat the beaming. I show these cases because we use 3 beaming, and we prefer to use 3 beaming and not only 2, because we consider the medium beaming like an anti-rotational system. Okay, and you can see the result of the healing wound after one month follow-up. And remember the 3 months of not weight bearing after this operation. And remember, you can use this procedure only in a sterile field. Otherwise, you have this problem. We have a female, 49 years old, with a bilateral Charcot known since 2022, with a chronic osteomyelitis for the past 3 years, with multiple treatment, revascularization, and all. We have a deep ulcer with probable bone and osteomyelitis factor. And so what to do in this case? To think about other proteases of the metatarsic with bleeding after debridement, or we do a debridement with hybrid external fixation, or do only a vulvarectomy, or do nothing and continue with the medication and the orthopedic foot. Good choice. And this, in fact, we use a hybrid external fixator that Prof. Wolf talk later. We use this type of fixator since 2010, I think. And this is the result after the operation. We clean the wound. We remove a lot of bone in metatarsic, and we implant the fixator. Remember that this type of fixator neutralizes the load force along the mid-arthrodesis, but don't do a compression. And so you have to maintain this fixator a lot more than a beaming, like 6 months. Here you can see the beautiful result after 10 months after the operation. We have a consolidated arthrodesis and no more sign of inductive infection, but I did a mistake in this case. I didn't remove enough bone in the middle part. And so now what to do? We have no sign of infection. The patient asks for surgery. I can choose to do a shortened osteotomy and beaming, repeat the osteotomy, or fill the lateral gap. In this case, I choose to fill the lateral gap, and I do a partial osteotomy of the midfoot, and I put a heterologous bone graft in the lateral part of the midfoot, like Evans osteotomy style. And you can see the result after 1 month, and let me know how it goes. And here the last my last cases. We have a female, 49 years old, with diabetes mellitus from 20 years old. It's an obese patient with a BMI of 31. It has a bimalleolar fracture in 2023 that they treated in another hospital with a standard fixation. You can see the X-ray after 14 days after the operation, and you can see something start moving in this ankle, but the patient start walking, and you can see the result after one year, and the video don't start, but we have a complete instability of the ankle with very severe varus deformity. And so in this case, we have no sign of infection. We have a not active Charcot, but the patient suffered by a very severe lymphedema. And so what we can do in this case? We can think about an amputation. We can think about a arthrodesis of the ankle with either external fixation. We can repeat the ORIF, or we can do other arthrodesis with an internal rod, and so put a bleeding. Okay. Most of the surgeon think about to do an internal bleeding. In this case, I repeat the road of the hepatic fixator because I was afraid about the lymphedema. I do lateral approach. I remove all the hardware. I do the arthrodesis of the ankle with the fibula like a bridge, a bone graft fixed with a 3.5 compressor screw. And you can see the result after 1 year. You can see how big is the lymphedema of these patients. And you can see the result is quite nice. Okay. And let's go with the presentation. Okay. Okay. And we have the case type of Walker.
Good evening to all, and thank you for the kind invitation.
Thank you.
In the case of Mr. Giovanni, you see the severe bone loss of this patient, severe Charcotic instability of his foot, and the options are amputation, elixir of external frame, with progressive correction and distraction. This is possible. Double plating with bone graft, or massive bone graft with external frame. What is your choice? Difficult case or not?
Sorry, we have black rectangle.
Yes, we don't see the proposals.
We don't see your skin, Dr. Volpe. Your screen.
Sorry?
We don't see the screen.
Now you see?
Okay. Now, yes.
Okay. We repeat the case. We start the cases. So okay, no. It's
just a few seconds for the results.
You need to see any more there. Okay. So we can go to the details. Okay.
Okay.
We perform with open approach. We do a progressive alignment, and we stabilize the alignment with percutaneous K-wire. Then we take a massive bone graft from our bone bank. This is a femoral condyle. We accommodate, we remodel the condyle, and we accommodate the condyle inside the bone gap, forcing the position to obtain a good stability. We stabilize the position with K-wire, and we put an hybrid external frame. You see the connecting arms to stabilize very well this kind of situation. And this is the result of Mr. Giovanni after 6 months of treatment, a good bone healing and a stable foot. This is very, very important to have a stable and plantigrade foot. And this is Mr. Giovanni working with his leg without any kind of pain. Let me to complete this presentation with some observation. In my opinion, external frame, hybrid or circular, is a good indication when ulcer or previous ulceration, in chronic osteomyelitis requiring debridement and stabilization, and if in case of large bone dissolution, involvement of ankle and contemporary Chopard-Lisfranc, is stage 3 and 2 of Sanderson-Friedberg. And with the external frame, we obtain a superconstruct stabilization, bridging, and to have a multi-point stabilization. This technique was proposed by Cooper and other colleagues many years ago, and we have the honor to have in our hospital doctor with Luca Dalla Paola, also Dr. Sanders, and this is the external frame. I think you know very well this orthofix device. How we approach this case? In any case, with open approach or request, lateral or medial according to the kind of deformity, with removal of necrotic infected bone, interruption of the very strong fibrotic and bony bridges that opposes to good alignment. We correct all subluxation and luxation. We perform a bone contact better as possible. We arrange to create a plantigrade position with a smooth plantar surface, is very important, and fixation with temporary KY before frame position. And this is how we do in the operatory theater. Then we mount the tibial body with 2 pins, H covered pins. We assemble the distal ring at the right level. We drive a posterior cross K wire in the heel. We drive 4-foot K wires, usually parallel. To check the correct position of foot alignment in unlock position. We adjust compression. We look at the fixator in final configuration. And we stabilize assembly with reinforced bar. I remember that the axis, we arrange the foot in correct axis. And our goal is to create a stable, well-aligned plantigrade foot without any bony prominence, easy to accommodate in orthopedic shoes. And it's important to observe that the bone fusion is not always required, but we look for a stable, close fibrotic contact can be also considered a success in this kind of patients. And closing our speak, we remember that the treatment of Charcot needs to be carried out by a teamwork composed by diabetologists, orthopedic surgeons, radiologists, and podiatrists, possibly in special unit like our foot and ankle clinic. In our opinion, correct time for surgery of Charcot joint is a quite stage, indicated as stage 3 of Shibata classification. Indication for reconstructive surgery are limited to gross instability, recurrence, ulceration, and ambulatory deformity of rear foot and ankle or both. It's important to eradicate infection prior to surgery or sometime during surgery. It's mandatory to treat appropriately this vascular limb with percutaneous revascularization prior to go to surgery. The external phrase remains inside for 6 months or more and consequently needs appropriate handling and maintenance, careful and regular medication supervision, together with cooperation of the patient is required. After bony or fibrotic fusion in well-aligned plantigrade foot, an orthopedic treatment with special shoe and brace is advised for the entire life of the patient. This, I go to very important concept for me. Our group showed that Charcot can be dysvascular in 30% of cases. Is a lot of patients. And this is a typical diabetic situation is a low arterial compression is in the popliteal fossa, and it's very important to go distally as possible. Advantage of external frame: external fixator aligns in the same time ankle, rear foot, and midfoot. Is easy to handle, so we can customize it to many kinds of deformity with flexible tridimensional construction. Multi-point stabilization in osteopenic bone is very important. Dynamic multiplanar stabilization, because we can arrange many times the better position as possible for the foot. Many correction can be done. And after fibrous union can be converted to rigid state fixation. Partial and full weight bearing is allowed treatment according with appropriate healing time. Is indicated also for septic cases because we have a room for medication and back therapy, and it's possible to redo to perform another revascularization that is not so usual in our kind of patients. And comparing the external frame with a circular external frame with the hybrid external frame, in the monoaxial hybrid frame is reported more problem of tibial pin track. But in our experience of 208 patients, we have only 2 situations of loosening of tibial pins or tibial pins fracturing. And thank you for your kind attention.
Thank you, Dr. Volpe. Thank you for a very impressive presentation. And surgery, little bit, we are not used to this kind of surgery in this kind of pathology. So I open the mic for our colleagues if they have any remarks or questions. Dr. Abdel-Noor.
No, I'm very impressed, but I'll be very honest. I think most of these middle-aged patients who have a Charcot joint with all this doing and they want to return to labor, I'm kind of wondering whether doing all this surgery and comparing it to a simple thigh amputation, whether the patient will do better or not. You know, we have to think of the expenditure of these patients. In many countries, the government won't pay for these procedures, many procedures on it. And as a result, we are forced to carry out a certain treatment that we're not convinced of. Anyway, I congratulate our colleagues, the Italians, for such an educational meeting. We learned a lot from them, and we hope that we'll be able to carry on in the same treatment. Thank you.
Thank you to you. In Italy, the limb salvage surgery is our mission, because you know how high is the risk of this kind of patient after BKA amputation or above knee amputation, and the expectancy of life in the next year or in close time go very, very low. So if possible, we try to reduce much as possible the number of amputation in our patients.
Yep.
And let me to stress the concept of dysvascular limb also in Charcot. The Charcot is not only a neuropathic foot, but sometimes is neuropathic and neuroischemic foot. So it's very, very important in our mentality to perform a vascular study before treatment, and during the vascular study is possible to perform a percutaneous revascularization in many cases with special medicated stent, also in small peripheral arterial supply.
May I ask you one simple question? Supposing you've done all these procedures and you've had such a wonderful result, and the patient has a recurrent ulcer and problems, what would you do next?
This is a difficult question. We explain to the patients that the risk of amputation is high.
Exactly.
Sometimes we have to explain to the patient that the next possibility is only amputation.
Yes.
Thank you very much.
In a recent study, the rate of major amputation, the mortality at 5 years is about 56%. So it's very, very high mortality after 5 years after a major amputation for diabetic foot. Of course, not because of the amputation, but because of the context. And so if we can avoid amputation, it's always good. And congratulations another time for your techniques that you are developing in Italy. So is there any other questions or remarks to Dr. Volpe?
Thank you, Professor Volpe, for this impressive presentation. To say something to Dr. Abdenour, even when I say I operated like 14 or 15 of these patients with a Charcot foot of the ankle, and even when we say that they have a rate of 70% of amputation, if we operate them, they say, okay, go do it. So the psychological effect of an amputation is really difficult to manage for patients.
I do agree with you, but let me tell you, don't forget that you have a neuropathic foot. This foot is insensitive to pain. When you fuse these joints, the consequences of injuries are higher than when you have multiple joints. I'm kind of wondering, I'm trying, it's not my specialty. I'm just asking to learn from you people. But I'm telling you, you have to be careful. These patients have a peripheral neuropathy. They are condemned, and they're going to continue to injure their feet. I don't know. I want to ask our Italian friends about this. What would you do with the peripheral neuropathy?
These patients are neuropathic. For this reason, we recommend a very, very close management of this kind of patients. And for this reason, we have arranged in our clinic a strong group of podologists and podiatrists.
Psychologists.
The podologists.
Psychologists, no.
We don't have for monetary reason psychologists at this time, but we ask to have also a psychologist because the patient have to change his mentality and to change his type of life and to participate of the treatment of his problem in foot. This is very important because there is a lot of information to go to this patient regarding the control of the skin, also by the familiar and to control the good shoe, the use of good shoes, to do not increase the body weight, and many our education points.
Thank you.
Okay, thank you. If I have to summarize all that we've seen this evening, first, dealing with diabetic foot must be a multidisciplinary management. It's not only about surgery, and we need to control all the aspects of the pathology of the patient. The patient diabetic foot is not just a foot, it's a diabetic patient with a foot problem. Second thing, we can say that a mild trauma can result in Charcot foot. So we need a high degree of suspicion if after a mild trauma in a diabetic patient after a few weeks and the problem is not resolved, we have to think about and to search about this. We saw also that plantar foot ulcers can be addressed very good by DMDO, percutaneous osteotomy with immediate weight bearing, and we saw the excellent results. So we need to have also the excellent indications. We saw also that in case of posterior Charcot foot or hind foot Charcot, we can use the arthroscopy in addition to the intramedullary retrograde nailing or external fixation to fuse and to heal the skin wounds. And finally, we saw that in case of midfoot Charcot, we can use these new techniques presented by Dr. Marco, the beaming associated or not to external fixation. So it remains me to thank you, all of you, for your attention. Thank you to all the moderators, the speakers, and the audience, of course, for your attention. You have been more than 60 people this evening to discuss about this very important subject. And our last thing to do is the traditional photo. So we will ask you to, all of you, to open your cameras, and we will take a screenshot of all of
camera,
you.
Please. All of you.
Everybody open the camera. We will take a screenshot. This is tradition of our meetings. So everybody open the camera, please. Oh, I think nobody's here. Okay. So we'll take a photo,
Okay.
a screenshot, and thank you to everyone for your attention, and see you in our next meetings. Goodbye.
Bye. Thank you.
Thank you.
Ciao. Ciao. Ciao.
Ciao. Buonasera. Buonanotte.
Goodbye.
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 Bye.
Thank you.